Buenas tardes, buenos días.
Good
Les
afternoon
recuerdo mi
and good
nombre.
morning,
Os habla el doctor Pablo
wherever you
Cardinal.
are. My name is Pablo Cardinal. And for me, it's a great privilege and honor to present at this symposium, to introduce at this symposium Dr. Carles Subirá. Dr. Subirá probably is well known to many of you. He's an outstanding intensivist in one of the most important hospitals in Barcelona, Hospital San Pau. And he has a very strong activity as a clinician and researcher. And now he is taking over the responsibility to improve the digitalization. And that's exactly what he will be talking about over the next 20 minutes. The symposium is sponsored by WFICC. He will be speaking about the power of data in the ICU and how can we digitalize a clinical care medicine service. Carlos, thank you for accepting our invitation, and you have the floor. Good afternoon, everyone. Thank you, Pablo, for this introduction, and welcome to the symposium. I will try to share my screen. Can you see my presentation? Yes. Let me introduce myself. My name is Carlos Subirá. I am an intensivist at Sao Paulo Symposium in Barcelona. And this Better Care Symposium wants to go deeper in data digitalization to help our patients. The objectives of my presentation include understanding the evolution of monitoring and data in the ICU. I will be presenting some real solutions of multimodal monitoring and management of data of the critical patient, and finally some real life examples of how digitalization helps us to treat better our patients and has an impact on our daily clinic. I would like to start with the history of the ICU. This picture was taken in Denmark during the polio pandemic, late in the 40s, early in the 50s, where patients with poliomyelitis that required ventilation with negative pressure. Hospitals decided to put them in the same rooms with the nurses and physicians to have better control of their patients, to rapidly identify any worsening and to be able to act promptly. Later on, the first ICU were developed. Critically ill patients that required monitoring were located in hospital floors. So we started seeing the first monitoring systems, basically electrocardiograms. Nursing played a very important role because nurses were responsible for identifying any changes and alerting physicians in case of a decline of the patient. Later on, we learned that all the vital signs of the patient in a flow sheet helped us to have a more comprehensive view to know how our patients were responded to treatment. So we can have time records with vital signs, the ventilator settings, and how these vital constants changed based on the actions implemented in our patients in order to have a retrospective view of the last 24 hours. These type of records, however, have some limitations. These are records which are done on a time basis. We lose the continuity of the data, or fragmented data, not continuous. Many of these data are incomplete. We depend on nursing from making notes of any abrupt changes that have been experienced by the patient. And there can be a loss of information, of course. This was the ICU a couple of years ago, and this is my ICU nowadays, a high complexity ICU with a patient totally monitored with a lot of machines, and practically all human beings have been replaced by machines. So this gives rise to the explosion of data. We have bedside monitors constantly giving us figures. We have hemodynamic monitors, resuscitation after shock to predict what we need for the patient. We have monitors telling us about intracranial pressure and oxygen in the brain, pressure monitors in the airway, and devices such as impedometers telling us how air is distributed inside the lungs, hemodialysis monitors, well, a lot of information. And this is big data. So in the ICU, we generate a lot of data a minute after minute. However, I insist about the paradox of massive data. Let me speak about the experience in my hospital, São Paulo, and how are we doing with interconnectivity? Our hospital is a university third level hospital. It's a reference hospital for high complexity patients in Barcelona. We have modern equipment and latest generation equipment, but each ventilator, each infusion pump, each monitoring tool works isolatedly. Interconnectivity is very important. So we have all these monitors that give continuous information on the screens. The problem is that each one of these devices work as a separate unit. Each company has its own protocol of how to give the information and the data. And then we will discuss how we extract that information. Moreover, these monitors are not interconnected, as I said before. So we have to input all the data ourselves on a paper chart or the electronic medical record. And this is done by nursing, but it involves a huge burden for nursing. And there is also the risk of mistakes, transmission mistakes, or just forgetting to write down important changes in the patient's progress. And this is the typical image, at least in my ICU, of the very complex patient with a lot of monitors and numbers and a nurse that is making note of all of those numbers into a piece of paper or a computer so that then we can study them. And then if we want to retrospectively review the data, many times we find that if there is a chart, either electronic or in hard copy, many of these data are discrete, are notes taken every hour. And if we want to extract the information directly from the devices, we can extract that information with a USB memory. But this data is given every 5 or 10 minutes, and we have to do it separately on each device. So we have granular data. It is true that in the market there are some solutions which allow us to integrate the information of the ventilator, impedance, the bedside monitor into one single screen. This is useful, but it gives us a lack of freedom when we want to choose which device, which ventilator, or which monitor we want to use in our patient. If we change brands, there is incompatibility of brands. And this is where our company, BetterLink, works. This is a tool that interconnects all devices regardless of the brand or model. Once they are interconnected, all parameters are extracted, alarms and continuous waves automatically and in real time. All of these signals are standardized, are transferred into the same language, are consolidated, and then are decoded to show them on a screen so that we can see them in real time and continuously. This screen is live, so we can very closely monitor the patient continuously. practically from any point in the hospital on real time. This screen gives us continuous data. Here we can see heart rate, the ventilator information, parametric data such as the settings of the ventilator. We can see them remotely. Mechanical ventilation waves. We can check the alarms retrospectively, and we can make an analysis of what is happening to our patient on real time in a very centralized way anywhere in the hospital. So our response can be more timely and we can anticipate complications. And finally, when we have spoken about how difficult it is to review retrospectively this data, we have another tool to allow for this retrospective revision up to 96 hours from the current moment to identify patterns, correlate different vital signs, mechanical ventilation waves, and we have continuous data of the electrocardiogram parametric data of the ventilator setting over the 96 hours. We can develop trends, and this is a real-time analysis from the present time up to 96 hours before. We are on the World Day of the Critical Lung, and here we can retrospectively review the mechanical ventilation waves from this screen, analyzing any events in mechanical ventilation. We can identify the exact moment or a few seconds before if things were not going right. Let me give you some examples of how the data based on continuous granular and viable data, we have developed some algorithms so that we can have a clinical precision. These are some of the first articles with the software of Better Care. It's very simple. Better Care analyzes retrospectively thousands of patients in mechanical ventilation, and Better Care automatically identifies not just whether breathing had been triggered by the patient or it was triggered by the ventilator, and identify what type of ventilatory mode is being used. This is very important for the next algorithms which have been validated with Better Care. This is one of the first ones we validated, analyzing retrospectively hundreds of thousands of breaths of patients on mechanical ventilation, analyzing the inflections in the flow expiratory wave. With Better Care, we were able to automatically identify any changes with a high sensitivity and specificity. And also, when analyzing, for instance, with reverse triggering, more recently, we analyzed a cohort of patients retrospectively who had been monitored, and Better Care was able to identify the reverse triggering, whether simple or with compounded. This is a more recent article on patients with esophageal monitorization and the retrospective analysis of the ventilator waves. We were able to classify the breaths according to the inspiratory effort. The inspiratory effort, just analyzing the inflection of the pressure wave, the inspiratory effort was classified into normal, moderate, severe, or severe double cross. And in the future, this may have some impact and application in clinical practice. And this is the last paper I will show you. This is something we did in Toronto. Patients monitored with Better Care system with respiratory distress. We monitored with a portable electroencephalogram continuously. And what we found were very interesting results. Patients in the acute phase of mechanical ventilation spend up to 50% of the time in electroencephalographic patterns that were never observed before in subjects outside the hospital, what we call non-natural patterns. And this is related with the higher the doses of sedative, the longer the patients spent in these patterns, which were not natural. And those patients who died in the ICU had longer with abnormal electroencephalographic patterns than the patients who survived in the ICU. And this is to show you that all of these validations of asynchronous have an application in daily clinical practice. This is from the workstation. Here you can see the ventilation waves, one, and we see in red that better care is identifying asynchrony, and later on it detects another asynchrony. So this information is given to us by the workstation in order to be able to analyze prospectively the asynchronies of the patient. And the data, I think this is very important. This slide summarizes what, in my opinion, we have to do with this digitalization of the data. We need granular data to analyze retrospectively what happened to our patient, so that in the present, after analyzing this data retrospectively, we can make a diagnostic analysis and find what actually happened to the patient, why, and then to make a predictive analysis of what will happen to the patient in the future to be prepared. And in the future, when we have the data and the algorithms validated, a prescriptive analysis. What do we have to do to prevent these from happening to the patient or to promote a good outcome? And I would like to finish with this slide. We focus on the patient in the ICU, where the patient is closely monitored, but most of the patients come through the emergency department. When they get worse, they are transferred to the ICU, where they are connected to the ventilator and are closely monitored with all of that data I already mentioned. If they improve, they go to the hospital ward, and if they survive, they leave home or for long-term care with a certain number of sequelae. And this is important because this is what we call the patient journey. And what happens to the patient in the ICU will have a direct impact on the long-term sequelae. That's why it's important not to lose sight of the fact that the patient is dynamic. And to conclude, I would like you to know that in the ICU, we generate a huge amount of data, but these data are only valuable when we are able to interconnect them. If we want to digitalize, we need real interconnectivity. And in my opinion, this has to be based on open platforms to integrate independent devices, regardless of the model or make or brand. And the obtention of these granular data, thanks to digitalization, reliable data, helps us to do quality research and develop clinical algorithms which have a real impact on our patient care. Thank you very much. This is the QR code if you want additional information about better care, and I will be pleased to answer any questions. Carles, thank you very much for your presentation. I would like to encourage the almost 500 participants that we have now to ask questions through the chat. And in the meantime, I would like to ask you a question. Specifically now in San Paulo, what are you doing at your hospital? How have you done the transition from the original picture of the written hard copies to the current digitalization? Is there any rejection by physicians or by nurses? Because every change generates rejection, which has been your experience. Yes, in fact, this is one of the things we have analyzed. This is one of the threats when you want to digitalize the ICU, the resistance of the practitioners to this change, because that changes their paradigm. So now we have everything ready to interconnect, and we are waiting to take the complete digitalization step. I do have experience in other centers. I used to work for a smaller hospital, and we managed that monitoring became practically automatic. The nurse, well, we decided that the medical record collected every hour, all the data, and the nurse only had to analyze the parameters, and it was totally automated. So the nurse had more quality time to spend with the patient. Perfect. Another question, which is rather personal. We are far from integrating all the data, but we are giving the preliminary steps like telemetry, centralizing monitors, pumps, etc. And my problem is that while I have everything on one screen and everything is recorded on real time, it's very difficult to take the data out for analysis. Can you do that? Can you collect the data for analysis? Is that easy? How do you do it? How do you take that step? The registration and integration of data, and then generation of knowledge, because these are two different things. Yes, we have to think that better care is designed for a clinical application. I think that the screen allows you to make this retrospective review back 96 hours. You can use the same screen if you want to see the blood pressure, the airway pressure, backwards, forwards. It's totally flexible. And you can put the screen whatever you want. And when extracting the data, you need a friend in the IT department to facilitate that data in whichever format you want so that you are able to analyze that data in Excel or MATLAB or whatever. Well, you must always have friends, Carlos. That's the truth. You need friends. That the same happens to me. I don't know whether there are any questions in the chat. Any questions from the audience? Obviously, ICUs will continue on this path. The paper chart will be a souvenir that we will remember from past times. Well, there are no questions. Oh, I'm sorry, Carlos. No, I think that what you say is very true. And one of the differentiators is that this flexibility and the connectivity. We do have multi-model monitoring systems in the market, but you have to have all your devices of the same brand. And with our system, you can have different types of ventilators, and all of them will be connected to better care. Different hemodynamic resuscitation monitors that can be interconnected, and that's the most interesting part. A question by Alejandro Castro. Higher precision in follow-up, a higher possibility to identify abnormalities and implementing interventions, which is very reasonable.
So
How
the
would
question
you
is how to
prevent
avoid overintervention generated by an excess of excessive monitoring. Well, I don't know if they are referring to abnormalities, because they're saying that an alarm comes off saying that something is happening. And I think this is where health professionals have to come in. Our role is to learn to identify what is important and what are false alarms or overexposures, and learning how to distinguish between them. You have the tool, but you have your own knowledge to be able to identify all of that. Well, Carlos, thank you very much. We ran out of time. I think it has been a very clear conversation. Thank Vital Care and you for your time. And I want to say goodbye to all of the audiences, inviting you to the next session that is very interesting, a session organized by the World Intensive Care Federation by Dr. Perez Fernandez and Jorge Hidalgo. And they will speak about differences in acute pulmonary lesions and their management in different continents. I think this is very interesting. Thank you, and we will see you next year. Thank you.